Within the myelofibrosis patients, we have usually 4 types of patients based on the prognostications of their longevity. The low-risk patients have an average survival of 11 years, and intermediate group patients 4 or 8 years, and then high-risk patients 2 years. Ruxolitinib is indicated in the United States for patients that have intermediate or high risk of dying, and this is very good to identify if we know how to, using the international prognostic scoring systems, and also to look really just whether the patient suffers from what the ruxolitinib is good for. And that is progressive splenomegaly, that is systemic symptoms that bother patients and decrease the quality of life. Within these groups of patients, intermediate and high risk, for the patients with these characteristics, the ruxolitinib is certainly a very good choice, and it will, in great majority of the patients, control the signs and symptoms and eventually make people live longer.
The optimal timing to initiate a JAK inhibitor or ruxolitinib, which is the only approved agent at this point, is unclear. The COMFORT-1 and COMFORT-2 studies looked at patients with more advanced disease, and these were randomized studies either to placebo or to best available therapy, both showing an improvement not only in terms of response, but in terms of quality of life, as well as survival to those patients who were randomized to the ruxolitinib arm. Now, the timing of therapy is in question. Should this therapy be used earlier? Should this therapy be used in patients with lower risk disease? And that's just unclear. What I can tell you in my clinical practice is I look at the prognostic scoring system. I evaluate a patient based on the IWG at the time of diagnosis, and I follow the dynamic score throughout to try and help me assess the time to intervene. But I use my clinical acumen, such as, is this patient's spleen size rapidly growing? Why is that important? Because patients, at least in the COMFORT-1 and COMFORT-2 studies, typically saw roughly about a 50% reduction in the size of their spleen. So if you wait too long when the spleen is extremely large, you're just not going to see as huge a benefit. So earlier intervention in that particular case may be important. When a patient has constitutional symptoms as a second clinical sign of progression, patients who are having trouble sleeping at night, for example, because of fevers, night sweats, or troubled by pruritus, these are times when intervention may really improve the quality of life. Fatigue is another one. Patients can have really dramatic fatigue, inability to get through the day, inability to complete work, and I've found that intervention in these patients can be really a quality of life or disease modifying, if you will, improvement in their outcome, and really has dramatically impacted the improvement in their well-being.
The evidence that we have about the ruxolitinib use in myelofibrosis comes from clinical studies. And recently we had a long-term summary of a COMFORT-1 study where it was presented that patients that start earlier with ruxolitinib versus those that do not fare better. The same was seen a few months ago in another controlled prospective randomized study where ruxolitinib was compared to best available therapy. In both studies, survival benefit is evident if you start ruxolitinib earlier. That means that we should not be waiting in everyday practice for patients to really be in a bad shape, what I say. If the patient has intermediate or high-risk disease, one should be looking at the spleen or symptoms, and if those are present, there is no reason to wait with the therapy. If the patient is suffering from symptomatic splenomegaly or general symptoms, that is, for me, very good indication to start with ruxolitinib, because evidence suggests that with the earlier intervention in patients that suffer from the disease signs and symptoms, we not only control those symptoms, but make them live longer. So the question is whether the early intervention with ruxolitinib in patients that even do not have a spleen or symptoms would make sense to prolong their life. This is a real question. It is being studied in a prospective randomized study in Europe as we speak, where patients that have a low-risk disease without any problems at all are being randomized in blinded way between the ruxolitinib low dose and watch and wait approach, which is still standard practice here in the United States, to see whether early intervention will make a difference. So prevention of the symptoms and prevention of the spleen will make an impact on the survival of the patients.